Good afternoon, and welcome to today's webinar hosted by the First Illinois of HFMA. The topic of today's webinar is Home is Where the Hospital Is. Before we get started, I would like to review a few housekeeping notes. 1. All phone lines are on mute to avoid interruptions during the broadcast. 2. In your audio panel, you may select to listen to this broadcast using your computer's mic and speakers, or you may select phone call to receive a dial-in number. 3. To access the copy of the presenter slide, please expand the Handouts panel located to the right of your screen and select the PDF file. 4. At the conclusion of today's presentation, we will have a Q&A session. However, you may submit your questions at any time using the questions panel located to the right of your screen. I'd like to welcome today's guest presenter, Chad Mulvaney. Chad Mulvaney is a Healthcare Finance Policy Director for the Healthcare Financial Management Association. Based out of Washington, D.C., he is responsible for analyzing the implications of legislative and regulatory developments on healthcare providers and is also a contributor to HFMA's Value Project research. Chad is a regular columnist in HFM, the HFMA magazine, and speaks frequently on issues related to health reform. Chad is a fellow of the HFMA and holds a Master's of Business Administration from the University of Maryland. He is active with the Virginia chapter of HFMA. He has served as a past board member. Without further delay, I'd like to hand the call over to our guest presenter, Chad. Please go ahead.
Thank you, QL. Appreciate the introduction. Certainly, it's great to be here with everyone. Hope everybody's having a good day and hope you're all ready to have a happy Thanksgiving. Want to spend the next hour with you talking about something that to me is interesting, and certainly wrote an article in HFMA's magazine, HFM, about the potential for a hospital at home model. And when I say potential, the potential is for it in the Medicare fee-for-service system. And certainly it's maybe not in the pipeline for CMMI, but it's certainly something that, as we'll discuss, is kind of on the shelf of things that they might be able to pull down and implement pretty rapidly. But the other thing that I think is important to realize is, even though this is sort of a on-the-table question for Medicare fee-for-service, it's certainly a model that is currently being deployed in certain places within the Medicare Advantage space, which, from my perspective, is a growing book of the Medicare business, and also something that I think is going to drive a lot of innovation through the system. The genesis of this article actually goes back about 18 months ago, when Gordon Edwards, who is the CEO or CFO of Marshfield Clinic up in Wisconsin, was presenting to HFMA's academic medical center CFO council, and the theme of the discussion was innovative care delivery models. And he was talking about what Marshfield was doing with hospital at home. And the first part that caught my attention was, this is a group of fairly experienced industry professionals. They've kind of seen it all. And when you see all of them sit up, take notice, and start to ask really detailed questions, that to me is an indicator that they think they're onto something that could be interesting for their organizations, either from something they want to deploy or something that could be a challenge to their current business model. And so the other piece of that is I had the opportunity to learn even more about it through the comment letter process. HFMA about a year ago submitted a comment letter in response to a CMMI request for detailed information about potential ways they could take their different innovation pilots. And one of the things that we recommended to them, based on about 6 hours worth of conversations with Marshfield Clinic, both Gordon and their chief medical officer, is that this could be a viable way to really improve care delivery. So what I want to do with the time that we have today is really just kind of define what the model is, talk about what's changing in the environment that makes it much more likely, and then either from a health plan or a health system perspective, think about, how do you respond to this? What are the questions you should be asking about this? as you try to look over the horizon, understand the impact on your business, and also see where there may be some opportunities. And then obviously at the end of the session, we'll take questions. So just as a quick comment as to, why now? Why is now the right time for something like this? I think to start off with the patient preference and kind of keep the patient at the center of everything we're talking about, as a society, we generally over time have developed less tolerance for being inconvenienced, regardless of the sphere of industry that it happens to be in. And I think healthcare is no exception, particularly as we develop other alternatives. And when you think about it also from the hospitalization standpoint, no matter how good the hospital is, how great the food is, how good of a job they do suppressing noise at night, my guess is that when you're sick, you'd rather be at your own home because you're probably going to get a better night's sleep in your own bed than in a hospital bed. Because even with the best efforts to suppress noise, you're still going to get staff moving around the hall, potentially equipment, overhead announcements, a nurse coming in, worst case scenario to do checks for blood pressure, et cetera, for rounding. And so there are opportunities to do this in a home setting where you're going to be more comfortable and they can sort of work the schedule around you. There's also demand for value. I mean, certainly top of mind, particularly from where I sit in Washington, D.C., is there's a need to restrain healthcare spending. We need to find ways to deliver care in less expensive settings when it's clinically possible. If you think about Medicare, it's right now 15% of the federal budget, and it's projected to be 18% by 2020, so just 10 years from now. And a lot of that's spent on hospital services that I think within the next 10 years will ultimately get pulled out of the hospital and into either the home setting or a lower cost ambulatory setting. And then in addition to sort of the cost side of the value equation, there's the opportunity to improve quality. Beyond the patient satisfaction impact that we've already talked about, which I think is a huge part of the value equation on the quality side, is there are opportunities to improve quality simply by not exposing people to some of the pathogens that are already common in healthcare settings. So no matter how well you do infection control, your odds of being exposed to something that is devastating or could make you quite sick is much higher in a healthcare facility than it is even in your home. Then when you start to think about the enablers, certainly the payment models to support it, as I mentioned, CMMI through the Physician Technical Advisory Committee now has sort of an off-the-shelf hospital at home model, actually 2 of them that they could potentially implement. And you also start to see as more patients or more Medicare members shift into MA plans, certainly in an aligned system where the financing and delivery of care is integrated, it makes it far more likely that somebody's going to experiment with this because the incentives are right, as opposed to in fee-for-service today where not only do payments not exist, it's actually counter to a fee-for-service system. And then finally, there's the technology piece. Certainly the technology to do this at some level has been around since the mid-90s. However, if you think about the ability to communicate virtually, certainly that capability has improved. And then also the ability to deliver care in the home has increased substantially. If you think about what started out as a number of innovations in diagnostic equipment that were developed to provide these services in remote rural areas of developing countries, those same technologies can be brought to the U.S. or brought back to the U.S. and used to deliver care in home. So certainly the robust nature of the services that you can provide in the home has certainly grown as that technology has become more sophisticated. In terms of what you need to be able to do from a capability standpoint to deliver on a hospital at home model, obviously you've got to be able to get the durable medical equipment into the home in a relatively short period of time. And we'll talk about kind of the staging of how a patient ends up there. But there needs to be a quick turnaround time for the delivery of things like beds, IV stands, monitoring equipment, etc. You also have to have a fairly agile care team. So an ability to get the physician in the home if need be, and then also have nurses that can provide hospital level or acute level care with also physician or nursing assistants and home health aides that can come in and help manage the patient through the process. As I mentioned in the previous slide, you need different types of portable diagnostic equipment and also home monitoring equipment. Certainly that's part of the telehealth piece. And then I think one of the key pieces, because the patient's going to be in the home and you're going to be responsible in this model for the patient for many days after discharge, not unlike kind of the current hospitalization model where you're on the hook for certain readmissions 30 days post-discharge. You need to think about the different social supports and be able to address social issues that by being in the home, you'll have a much better understanding of than if you're just seeing the patient in the hospital. In terms of the types of conditions that you typically see in a hospital at home model, the 7 MSDRGs here that I've shown represent the majority of hospital at home admissions today. And this is just based on the experience of Presbyterian Healthcare Services out in New Mexico. And they're certainly at the vanguard of this. But if you look at it, those 7 conditions, when you look at kind of the national spread of DRG volume, it's roughly 6% of the total volume of DRGs provided by Medicare in 2015. Now, obviously, these are relatively low acuity DRGs. They have low case weights. So it only accounts for about 2.6% of the Medicare allowable payment. But when you think about it, 2.6% isn't a lot. But the other way to think about it, the other lens, is when you listen to investor calls, say, for for-profit hospitals, particularly during the fourth quarter of the year and the first quarter of the year, those calls tend to focus a lot on how things are going compared to trend for last year's flu season versus this year's flu season. And when you think about the types of admissions or the discharge DRGs that you get for people who end up getting admitted for exacerbations of flu, it's typically things like the flu has evolved into community-acquired pneumonia, so MSDRG 195, or the patient has become dehydrated and ends up needing to get admitted, DRG 641. So the fact that, just for those 2 DRGs alone, you have Wall Street very heavily focused on this because this makes or breaks a for-profit system's bottom line. I think it provides just a pretty quick sort of example of how this could be fairly impactful if you were to start to implement this model in a market and it started to move cases from a hospital into the home and what that might do to the hospital's bottom line. When you also think about the proposal that Marshfield Clinic put to the Physician Technical Advisory Committee, it included about 150 MSDRGs as a possible pool. And when I was talking with their CFO about it, Gordon, he thought that even might have been a little bit aggressive, at least out of the gate, because they're certainly not doing anything near 150 today. But his comment was that, we could probably do 30 successfully today, but as we gain experience with it, and as more surgeries start to move into the outpatient setting and move off of the inpatient only list, and a great example of that is total knee replacement. Who's to say that we couldn't start doing hospital at home episodes for total knee arthroplasty and other typically higher weighted MSDRGs in the future? So as I mentioned at the top of the session, this isn't a new care delivery model. In fact, the genesis of this has been around since the mid-90s. And what we saw is at Johns Hopkins, several physicians conceived of the program to provide safe and effective hospital-level care in the home. And a team of geriatricians developed the medical eligibility criteria and the basic clinical model. And as they were putting this together, they also thought, if we're going to deploy this, what's the study and measurement model to determine whether or not this is going to be successful? Roughly a year later, they launched a 17-patient pilot trial of Johns Hopkins Hospital at Home program, and it was found to be safe, feasible, and cost-effective. From 2000 to 2002, kind of fast forwarding, we saw a national demonstration that tested hospital at home with 3 Medicare managed care organizations, so Medicare Advantage plans, and 1 VA medical center. And the model met disease-specific quality standards at rates similar to an acute hospital. And the average length of stay for these patients involved in the model was shorter. Overall costs were about a third lower than an inpatient stay. And patients had lower chance of developing delirium, requiring sedatives, or even needing chemical restraint. So it was, when you think about patients, elderly patients, it didn't tip elderly patients into frail patients because of the experience of being cycled in and out of a hospital. And in addition, both patients and family members were much more satisfied with the care they received compared to those being treated in the hospital. In 2010, you saw a private-public partnership that tested the model, And I think the unique thing about the 2010 test was that this was the first time that you saw care being provided by a physician group, and it was also deploying two-way telecommunications technologies for a lot of the physician management to be done by video or by teleconference. And then in 2014, we saw Mount Sinai in New York awarded an Innovation Challenge grant from the Center for Medicare and Medicaid Innovation to develop the hospital-at-home model in a fee-for-service setting, and really to start to think about what a 30-day bundle payment for hospital-at-home might look like. So who's currently using the model? You know, very similar to the different pilots we just talked about, it's a number of the VA regions where they're using it. And that makes sense because obviously the VA is a capitated system. They own their own care delivery assets, and they also employ their own physicians. You've got Marshfield Clinic at the bottom of the slide, bottom center. They own their own physicians, or they employ their own physicians. They have their own care delivery assets. And in fact, they're one of the few hospitals I know that are actually trying to build capacity because their Medicare Advantage plan is growing faster than they have inpatient acute capacity, which is one of the reasons why they're doing this. And they have a large MA book of business within Security Health Plan, which is their health plan. You got Presbyterian out in New Mexico, certainly one of the early innovators on this. When you think about their revenue, they employ their physicians, and roughly 50% or more of the system's revenue actually comes from their own health plan. Hopkins, obviously, highly regarded academic medical center, large faculty practice plan, and they also have a small, not only MA plan, but also Medicaid managed care organization, and they have a fairly sizable population of Medicare Advantage special needs patients, or DSNP plans. And then Mount Sinai Hospital is kind of the exception to the rule in that while I do believe they have some risk-based contracts, I do not believe that they own their own, or they have a Medicare Advantage plan or product that they offer through an integrated health insurance portion within their corporate umbrella. So, long way to sum it up. Typically right now in deployment today, it's largely, the deployment of hospital at home is largely limited to health systems that also own health plans, or what we at HFMA would call aligned integrated delivery systems. When you think about how patients get admitted in a hospital at home model, most of them come through the emergency department. And essentially, there's a triage protocol that when the patient hits the emergency department, they will determine whether or not they're acceptable or they meet the criteria, and the patient's given the opportunity to opt into the program. But you also see roughly 30% of hospital at home patients come from either the physician's office, so a direct admit to the hospital at home, or an urgent care center. And I think both the physician's office and the urgent care center are important to think about as we start to see much more vertical integration within the industry. As you think about the number of health plans that are employing numbers of physicians, or if you think about health plans that are being acquired by retailers that also have potential urgent care sites. And I'll say more about that as we get into some of the implications of this. In terms of how care is delivered under the model, obviously step one is initiate the care. And so, most of the time, and I think it's probably best if the patient evaluation that I described in the prior slide occurs in person, and again, most often in the emergency department, it can be done by telephone from a community setting, so either the physician's office or an urgent care center. And at the same time that the patient's being evaluated, if they are a candidate for the model and also willing to sort of receive their acute care at home, that then triggers a care team to go out and evaluate the patient's home. And we'll talk more about that on the next slide. Because what you want to do, and then once the home sort of is signed off on, you then trigger the delivery of your necessary durable medical equipment, and required medical care begins. So once the patient determines that they are an ideal candidate for it, you then start, while they're sitting in the emergency room or the physician practice or the urgent care center, the administration of any fluids if they're dehydrated, IV antibiotics if it happens to be something like pneumonia. And you also then will assign responsibility for care to a physician and a care team. Once the first step is complete, what happens is the patient is transported home, and depending on their level of acuity or how sick they are, they could be transferred home in their own car or in medical transport. They're also, when they get home, are met by a caregiver at the patient home and a physician, either in person or through some type of online communication platform, either by phone or sort of two-way video conferencing, explains the treatment protocol. The physician assesses the patient, orders are written, and clinical staff, and this could include respiratory therapists, physical therapists, and other caregivers, arrive as needed to start delivering care. So administering additional IV meds, fluids, provide nebulizer treatments, and perform additional examinations, and also any diagnostic testing that needs to be done. So ultrasounds, x-rays, electrocardiograms. And then the final piece of this is, if necessary, meals are arranged. And so in most cases, they will figure out how to get the appropriate diet into the home to make sure that the patient is getting a diet that adheres with both the patient's condition and the care plan. And then, once all of this happens, the patient's vital signs are continuously monitored electronically, very similar to if they were in the hospital. In terms of care delivery, the physician visits the patient daily, either in person or more likely via a telemedicine platform. So there's sort of a conceptual rounding, if you will. And then to capture any decline in the patient's condition when clinicians aren't on site, providers will continue to use remote patient monitoring technology. And if the patient starts to decompose, you can the care team can get over there very quickly and assess whether or not the patient needs to be admitted to the acute hospital, or whether it's safe for them to remain at home. Once the patient is stabilized and well enough to return to activities of daily living, the patient is handed off to his or her primary care physician. And this is one of the places where you see some variability in the model depending on who's deployed it. Some of the systems that I've described that are participating in the model, they have the provider who is the care team for the actual hospitalization piece of the hospital at home model, maintain oversight of the patient for at least 30 days to ensure that the patient is keeping appointments and not suffering any adverse consequences. And during this period of time, the physician provides updates to the patient's primary care physician so that that sort of circle of care is completed and the patient's primary care physician is in the loop. In other instances, there is a warm handoff where the care team that was caring for the patient during the home hospitalization episode will work with the patient's primary care physician and his or her team to do a complete handoff to make sure that they understand that the patient was admitted to a hospital at home model, why they were admitted, the issues that they had, the meds that were prescribed, etc., to make sure that the physician is aware, the primary care physician is aware and can manage the care from that point on. I talked a little bit about the home evaluation process. There are some very obvious things that, as the slide suggests, are evaluated when the care team initially goes in. You're obviously looking to make sure that the house has electricity, running water, it's clean and good repair, that there's heating and cooling there's heating and cooling. But some of the other things that you wouldn't expect are also for the care team. You want to make sure that you don't have pets in the house that could pose a threat to the physician who would be going into the house, the nurses that would be going into the house, and little things of that nature that you might not expect. In terms of the quality and cost results from the hospital at home model, home hospitalizations have the potential to reduce the total cost of care while improving outcomes. And certainly the subsequent pilots or offerings that we've seen have achieved savings on par with what initially Hopkins experienced, so something in the neighborhood of about 30% for admissions. The lion's share of the savings have been attributed to factors such as lower costs for diagnostic testing and pharmacy in the post-acute phase of the 30 days after discharge, and also less clinical service consumption. And you also see a fairly significant cost avoidance due to prevention of complications. So reduced hospital-acquired conditions and also reduced readmissions. And the other piece, just from the perspective of the hospital, or the team that is providing the care, the entity that's organizing the care, You also typically tend to see lower staffing costs due to some of the flexibility in the model. So unlike in an acute care setting, you can sort of flex the staffing more easily to meet the needs of the patient, versus where when you staff an acute wing, in a lot of instances, it's a certain skill level of care that you're providing, regardless of whether the patient has had, or depending on the severity of the DRG up to a certain extent. The savings from one of the early trials have found, as I mentioned earlier about delirium, one of the earlier trials have found the incidence of delirium was about 63% lower. And when we talked with Gordon about the experience at Marshfield in terms of patient satisfaction, the Medicare Advantage members that were involved with the model found that their satisfaction with the hospital-at-home model was about 27% higher than clinically comparable patients who were hospitalized. Now, as you look at sort of the impacts on length of stay, readmissions, and in-stay mortality, which are all lower by degrees for the hospital-at-home model, this data comes from Presbyterian Health Services. These are clinically similar patients that are being compared, and you do see a distinct difference in outcomes, particularly around fall rates, in-stay mortality, and also readmissions. One of the things that I think allows for the better outcomes, particularly as it relates to readmissions, is that when you're in the patient's home, you have a much greater opportunity to address social determinants of health and other issues that trigger readmissions. So the clinicians that I've spoken with, when you talk about medication reconciliation, at least what I'm told, either in the clinic or pre-discharge in a hospital, you very rarely, if ever, have a 100% accurate medication reconciliation. However, when you do this in the patient's home, when you're standing in their bathroom, in their medicine cabinet, or wherever they happen to keep their drugs, you typically get a much higher accuracy med rec, typically 100% accurate. When you go to the top right, the nutrition assessment and education, not only will people potentially not tell you if they're having nutritional problems or if they aren't getting sufficient calories, they may sort of hedge on the types of calories that they're intaking. So again, if you're in the home, you can potentially start to teach the patient about the right types of foods to eat. You can evaluate whether those are available in their pantry. And if not, you can start to draw up shopping plans and potentially connect them with different food assistance programs that can address some of these issues and provide them with a diet that is better suited to their clinical condition. In terms of a fall risk assessment, that's certainly not something that you can evaluate when you have the patient in a clinic or as you're discharging them, but actually being in the home, you can look to see if they've got the last remaining 1965 shag rug that's 3 feet deep in pile and provides a very significant trip hazard for an elderly person. You can look for steps that are uneven or potentially damaged. As you can see from this picture, extension cords that are kind of fluttering all over the room. And then finally, when you have the patient in the home, it provides a much greater opportunity to provide education. Because if you think about discharge from a hospital, there's a tremendous amount of information that's thrown at them very quickly. The patient doesn't feel particularly well, and all they want to do is get home. In a lot of instances, the caregiver or the person who's picking them up has to get them home, get their medication, and then probably get somewhere else. Whereas in the home, you can take the time to sit down, have a conversation with the patient, and make sure that they truly understand the discharge instructions and what they're being told to do, and also really take the time to evaluate whether or not that they've understood. So why haven't we seen adoption of this model to date, given the fairly obvious advantages of it? And at the end of the day, it's the existing payment model or lack thereof. It's the greatest barrier to process because, as I mentioned earlier, unless you're in a capitated model, this model doesn't make sense, particularly in the event that currently under Medicare fee-for-service, there's no way to actually deliver this without and get paid for the services that you're providing, which, if they're successful, and data indicates that they have been, create significant value for the Medicare program. So with that sort of one barrier teed up, want to really jump in and talk about what's potentially changing. And I want to start by really kind of just talking about what the Physician Technical Advisory Council is. And this has, the PTAC was created by MACRA, and really the way I tend to think about it is its goal is to crowdsource ideas for innovative payment models from the industry so that the field has the opportunity to provide its expertise to CMS. So it's just a mechanism for physicians, health systems, health plans, and other interested parties to submit good ideas that are fairly well formed to a group of experts for them to evaluate and make recommendations to CMS. And I think one of the advantages to this is, and just as an example, if you think about the Medicare Shared Savings Program, I remember back in 2012 when the first proposed rule was released, as I was working with HFMA's members to develop comments to it, probably everyone that I spoke with automatically pointed to the way the benchmarking methodology and the way that it would get risk adjusted and adjusted for inflation year over year as a significant problem that would either advantage unfairly or disadvantage unfairly certain types of providers. And despite the fact that, you know, we provided that feedback to CMS, CMS had pretty much already baked their Medicare Shared Savings Program model due to budgetary constraints. They really couldn't address the issues that we called out. And now 6 years later, they're just getting around to fixing those models, or potentially fixing those issues in the Pathways to Success proposed rule that we expect to be finalized in the next month or so, or next couple of months. So that's one of the benefits. PTAC participants, you know, in general, the number or the types of people that they have pulled together, it's a fairly impressive group of people or professionals with healthcare delivery experience. So you've got physicians, you've got health economists, you've got individuals who have run delivery systems, and many of them have come from the Medicare Payment Advisory Council or Commission. So they've served on MedPAC. And the process, as you can see from the graph in the center of the slide, is rigorous. And there's a fair amount of give and take between the organization that proposes the model and the committee and the professionals on the committee to really push the thinking on the model design. And so, at least from kind of watching Marshfield's experience with their hospital at home model, they, as you can see, submitted a letter of intent. They then submitted a formal proposal to the PTAC. The PTAC sends the proposal back to them with suggestions for improvement, questions, things that they think need to be clarified, or potential design flaws in the model that they may want to think about ways to address. And then it goes back to the PTAC where they reevaluate it. And from that point forward, they make a formal recommendation to the Secretary of Health and Human Services as to whether or not the model should be tested or implemented. And there are varying gradients of that. So it's everything from, no, this isn't a model that we think has any merit to it, all the way to, this is good to go out of the box. And there's certainly, as I said, gradients in between of interesting concept, but it needs a little bit more work, and I think it would benefit from the professional staff at CMMI putting some thinking to it. In terms of the proposed models, just, you know, as a slide to give you a sense as to what people are interested in or have submitted to the PTAC, not surprisingly, we're seeing a lot of interest from the field in developing models for specialists and high-cost areas. When you think about specialists outside of the bundle payment for care improvement or bundle payment for care improvement advanced model, there really aren't opportunities, and in the oncology care model, outside of those three models for specialists to get involved and have an APM for them to qualify, aside from participating in the Medicare Shared Savings Program or other similar model, or one of the risk tracks in the MSSP. Not surprisingly, obviously, you see the specialist models, oncology, but also a lot of focus on primary care. And I think the focus on primary care is simply reflects the needs of small physician practices that may not want to participate in an ACO, looking for something that will still allow them to gain experience bearing risk and managing populations, or managing their populations, or even looking for a different financing model that will allow them to provide care that better meets the needs of their patient populations. in terms of the actual payment model for the hospital at home model that was proposed, or at least that Marshfield proposed, it looks very similar, at least in concept, to the payment models used in the Bundle Payment for Care Improvement, or BPCI, Comprehensive Care for Joint Replacement, CJR, and BPCI Advanced models. And that's basically, it's a retrospective model. So if this were ever developed and deployed as a retrospective model, what that would mean is that CMS will continue to pay all of the providers involved in the 30-day hospital at home bundle their standard fee-for-service payments. And then in the background, CMS would calculate a target price for each home hospitalization episode. And at the end of the performance period for the entity that's sort of managing the risk, there'd be a reconciliation of the actual spend of the target price. And the model proposed by Marshfield at least differs a little bit from CJR and BPCI in a couple of ways. Number one, episodes only 30 days compared to the 90-day episode that CMS seems to have favored. And then also, I think Marshfield has done a much better job, at least in their proposed model, of excluding services that are not related to the home hospitalization. And just to give you an example of that, so now in BPCI Advanced, or at least one of the flaws in BPCI Advanced, is that, say, patient has a knee replacement. As they're leaving the hospital, they get into a car accident and end up getting readmitted to the hospital. That car accident still counts against the bundle. However, certainly in the hospital at home model, that would get pulled out, and the trauma services related to that would be carved out, and the entity holding the risk wouldn't be responsible for them. The other interesting thing, and what's slightly new about this, is I said that it relies on the existing payment system. The one wrinkle in that is that for whoever's organizing and sort of providing the acute piece of the hospital at home model, they would get reimbursed the MSDRG rate, but it would only be 70% of the MSDRG rate to sort of account for the lower costs of providing services in the home. And then obviously the target price incorporates a 3% discount, so CMS in theory has automatic savings locked into it, assuming there aren't any impacts to the volume of care provided in this model versus in an inpatient model. In terms of measuring quality, the proposed model only includes outcome measures, which I thought was a well thought through component of the model. You've got the CAPS model, though my guess is if you saw this model delivered or developed and deployed broadly, you would probably see the development of a hospital at home specific CAPS survey. But for the moment, the clinical CAPS are probably the best corollary in terms of measuring patient satisfaction and experience of care. And then you've got 3 claims-based outcomes measures: mortality, readmissions, and ED utilization in the post-discharge period. And certainly if the model moves into an area where there are valid patient-reported outcomes measures, Marshfield also proposed to include these measures as well, which I think is a strength of the model. Because when you think about it from the patient's perspective, you know, if the only quality measures you're using are, for lack of a better term, failure measures. So did I as a patient get readmitted? Did I as a patient have to go back to the emergency department? Or worst case scenario, did I die within 30 days of the episode? Those to me are sort of table stake things that shouldn't happen in a high quality delivery system, even though they do happen. So as the patient, I would want to start to evaluate things like functionality, return to function, and achievement of certain goals that are reasonable given my health. Now, one of the other things that I think could strengthen the attractiveness of this model, and Marshfield certainly mentioned it, but they didn't specifically propose a track for it, is if you could create a track that would qualify for the 5% advanced alternative payment model bonus under MACRA and provide additional clinicians a way to get out of participating in MIPS. And certainly, I think this would definitely strengthen the attractiveness of the model. Certainly, because a lot of the physicians, particularly specialty physicians, don't have a clear way to qualify for the AAPM incentive. And certainly, if you've read or had an opportunity to peruse the 2019 final physician rule, CMS currently estimates that approximately 798,000, almost 800,000 clinicians will be MIPS eligible, clinicians for the 2021 payment year. And they estimate that they will, through the MIPS mechanism, disperse almost $900 million. So it's $390 million in sort of reallocated Part B payments from low-performing physicians to high-performing physicians, with an additional $500 million for exceptional performance for clinicians who scored over 75 points on their MIPS score. Now you contrast that to the approximately 165 to 220,000 clinicians that'll qualify for the 5% APM bonus. And those clinicians are estimated to get somewhere between $600 million and $800 million. So just kind of in round averages, you have the opportunity, if you're sort of stuck in the MIPS track, of potentially having to pay into it. And just on average, your best payment would be about $1,100, or go the APM route. And conservatively, that might be worth more than twice that, about $3,000 per physician. So certainly, if I were in a physician practice, I would be looking for an opportunity to go into the AAPM track to not only sort of take advantage of the bonus payment, but also get away from the administrative burden of being in the MIPS track. In terms of who might potentially participate in this type of model, chart on the screen gives you kind of an XY or XY axis view based on whether or not they actually own acute care access, so that they have a hospital, and also, how much experience do they have bearing risk? And you get a fairly defined set of potential participants. And maybe we'll just sort of walk through these one by one. You think about academic medical centers, many AMCs have reached or close to exceeding inpatient capacity. And they may look at a hospital at home model as a way to serve more patients without having to invest $1 million or more per bed to create additional capacity. The other way they might look at it is, in some cases, you're seeing AMCs acquire community hospitals, number one, to sort of extend the brand out into outlying areas, but then also, two, with varying degrees of success, to decant lower acuity procedures and condition or admissions into the community setting, so they can save the beds on the main campus, which is a more expensive setting, for the things that really merit the level of care that's provided in an AMC. And so the hospital at home model provides them a way to accomplish both of their goals without actually having to pour concrete. The model provides a way to divert lower acuity admissions to sites where care could be provided at reduced per unit labor costs. And certainly joint venturing with primary care physicians in adjacent markets may create an opportunity to leverage the AMC's traditionally strong brand and gain market share at the expense of other hospitals without actually having to buy acute assets. Moving over one to the top right, you could go with the aligned integrated health systems, which are the ones that to date have sort of experimented with the model. And certainly these organizations employ many of the physicians that provide care in the system, and they also own a health plan. Almost all of them are involved in some form of Medicare fee-for-service organization or Medicare fee-for-service ACO, and they also typically will have a Medicare Advantage plan within their health plan. And so for these systems, deploying the hospital at home model within their health plans and to their Medicare fee-for-service population means providing additional support for their population health management strategies, leveraging their existing care coordination capabilities, and it also helps them put more weight on the foot that's in the canoe versus the one that's on the dock. So it helps to kind of get them across the transition faster so that they've got more of their revenue at risk, and it really starts to become, the incentives start to become better aligned for the organizations. Down to the bottom left, ED staffing groups, probably a long shot to execute the model, but certainly something to think about. When you think about ED physicians, they are the ones that triage and write admissions orders for up to 70% thus far of the patients who have low acuity medical conditions that could be treated in a hospital at home model. Participating in the model could create a new revenue stream for ED staffing companies as well. So if you assume the model has if you assume the model has a qualifying track for the AAPM incentive payment under MACRA, episodic payments for home hospitalization could also provide a way for them to qualify for that and also get them out from underneath the MIPS track. But certainly when you think about ED physicians in MACRA, one of their complaints is that they're all kind of stuck in MIPS and there isn't a clear AAPN path for them. When you think about ED staffing companies from a capability standpoint, certainly they lack the capability to deliver home-based care, and they also typically don't have hospitalists with them. However, they could certainly they could joint venture with some of the national home care providers or some of the hospitalist companies to figure out a way to, put the capabilities together, manage the episode, and they could probably coordinate this through one of the companies that's out there currently providing the technology platform and the infrastructure to support to manage this. And certainly Marshfield's working with one of them. I believe Hopkins is also working with a separate company. So there are a couple floating around out there that will provide the infrastructure for different entities to do this, so you don't have to start from scratch. Moving into the bottom right, if you start to think about risk-bearing group practices, given their relationship and proximity to Medicare fee-for-service patients with multiple chronic conditions, there are a number of primary care group practice models that stand to gain financially from this model. And so the example that jumps out to my mind is probably most familiar to the audience is Oak Street Health in Chicago. And so if you think about Oak Street, it focuses on delivering care to historically underserved populations. Although its business model is typically predicated on subcap payments for primary care from Medicare Advantage plans, the organization does deliver care to some fee-for-service patients. And so, certainly they could work something out with the MA plans that they partner with, but if Medicare certainly rolled this out as a fee-for-service model, I would expect them to jump on this as well. And certainly these practices, by nature of what they do and how they position themselves in the market, have the analytic capability, experience with virtual monitoring and care delivery, and patient navigation to successfully execute the model. Beyond creating an additional revenue stream for the practice, adopting the model could enable these practices to develop deeper relationships with patients that are in fee-for-service that might serve as a stepping stone to get them into Medicare Advantage plans, which is, I think, their ultimate goal, because they want to get into the subcap space. But then also it allows them to develop relationships with home care companies and really helps to kind of refine their care delivery model. And then finally, you have health plans with home care delivery assets. And so we've certainly seen a tremendous amount of vertical integration within the health plan space, where providers have increased or even acquired new direct healthcare delivery capabilities. And these efforts are likely focused in part on decreasing utilization and costs for health plan members, and also helping to increase the health plan's market share. However, this strategy also provides health plans with a platform to generate incremental revenue by managing fee-for-service lives. And certainly the poster child for this is if you think about DaVita Medical Group, which was acquired by Optum, the unit of United Healthcare. They currently now have, with that acquisition, north of 37,000 employed physicians. And certainly this transaction is a prime example of a health plan extending its reach into Medicare fee-for-service, because DaVita Medical Group practices participate in Medicare ACOs in a number of markets. And in the 30 markets where Optum has physician practices, the practice's existing relationships with Medicare patients, coupled with their analytic capabilities, make them a natural entrant. So you could sort of imagine that it would not be hard for these clinics to educate their patients, hey, if you're not feeling well, particularly if they're patients with chronic conditions, hey, if you're not feeling well, before you go to the ED, give me a call if you're the physician. Patient gives you a call, you can certainly sit there and figure out, you can coach them through it, get them either to an urgent care center that you're affiliated with, or have them come into the office after hours, evaluate them, determine whether they really do need to be admitted to the hospital, or whether you could admit them into this model and really kind of cut the hospital out. In terms of our likelihood to see this in the near future in the Medicare fee-for-service population, certainly the PTAC elected not to move forward on any of the recommendations, which I think is a real missed opportunity. The varying reasons that I've heard from CMS as to why they're not moving forward on this more aggressively is simply, the administration has a very set agenda, and unfortunately the models the PTAC recommended don't fit neatly into that. And also, even Medicare has limited resources in terms of what it can invest in its portfolio, in its innovation portfolio. So if you think about this as being sort of sequestered to, for the time being, the Medicare Advantage market, I tend to think of my two most likely to deploy as either your health plan with care delivery assets, so Optum and its physicians, or say Humana Kindred or CVS Aetna. And CVS Aetna to me is intriguing because certainly we've heard as more has come out about the integration of the two, CVS's plans to turn a consequential number of their minute clinics into urgent care centers, which could certainly serve as a sort of funnel for this type of model. And I'll say more about Humana and Kindred on the next slide. I would also expect to see more aligned integrated systems deploy this model. So if you happen to have the health plan, so I would expect, and I don't know this for a fact, I'm just speculating, but shops like UPMC in Pennsylvania with their health plan, we think about that. Certainly Priority Health Plan up in Grand Rapids would be sort of a natural, and any number of other entities that where they have some experience managing risk in a capitated model where you might sort of deploy something like this. In terms of sort of thinking through the geography of this and where it's likely to spread, I think longer term, with Medicare Advantage being a growth market and 50% of Medicare beneficiaries projected to ultimately be enrolled in the plan in the very near future, I think you have to think about it at the state level. And I would certainly expect to see this in plans in Florida, California, Minnesota, Pennsylvania. And I'd certainly start to think about some of the bigger players off to the right. So your Uniteds, your Humanas, your Aetnas, where you have market share and market concentration, and it makes sense to start developing these partnerships, particularly where you have dense areas of Medicare Advantage beneficiaries to stand these up. I think the prime example of somebody who's, if they're not already doing this, will start to do this is Humana. Not only do they employ a number of physicians in many of the markets that they're already in, but with their acquisition of Kindred at Home, they certainly now have the home care capabilities to successfully execute on this model. And even beyond where they have employed physicians, Humana is also, in terms of a health plan, a very progressive payer, because they are experimenting with a number of value-based contracts with large, sophisticated group practices like Heritage. So I would imagine that if they don't have something like this structured with Heritage, it could be something that they would explore in the future. And I think the biggest signal to me is that where this is going is Bruce Broussard, Humana's CEO, on a recent earnings call said that he believes that an increasing amount of care will be provided in the home, particularly hospitalizations. So he's basically told the market that this is where they're going, and their goal is to take utilization out of hospitals as much as humanly possible. In terms of thinking about how to respond to this, to me, it's more of a framework for questions to ask. And so from a health system perspective, I think there are two cuts at this, right? You need to understand how much of your margin is attributable to admissions that can be managed at home. And I might sort of bifurcate this from a timing standpoint, given the uncertainty around what CMS may do in the fee-for-service population, by first looking at my large Medicare Advantage plans and figuring out how many of my admissions come from, for those MA plans, from those 7 MSDRGs on slide, I believe it's 7, and then also looking at the PTAC proposal that say either Marshfield Clinic or Mount Sinai put together, and see what MSDRGs they're throwing in there. And I think that, as you look at that, that'll give you a sense of what your exposure is. And then also think about what happens if you choose to cannibalize your own business should Medicare ultimately roll out a model like this. How would you have to make that up in terms of increased capacity that you create, and can you meaningfully backfill that capacity if you deployed your own model? From the health plan perspective, I think I'd look at it, obviously you look at it slightly differently. I think you look at what percentage of your Medicare Advantage patients are getting admitted for those MSDRGs, and then, what hospitals are they going to, where is the source of admission, and who are their primary care physicians, and trying to figure out who are the sources of these admissions, and figuring out what the opportunity might be to partner with them in some type of model that looks like this. I think in terms of understanding your opportunity, it's the two questions to address should be for the MSDRGs that will likely be targeted. What's the target price going to be? And this is from the health system side. And then the other question is there excess utilization or testing that can be reduced? And I think kind of the quick and dirty way to do that would be to look at a hospital's Medicare data on the Medicare spend per beneficiary. That's part of the hospital value-based purchasing program. And so looking at for each MSDRG, where is their opportunity to potentially reduce readmissions? Where is their downstream testing and other ancillaries that don't seem like they might be needed? And could you put protocols in if you were going to drop a model like this on and wring utilization out? I think you also need to understand the market. We talked a little bit about that, but I think it's also understanding if Medicare fee-for-service did this, what other types of entities would you be competing with for the home-based admissions? And I think, it's understanding additionally what physician practices are responsible for the referrals for the conditions that can be managed at home, and also who else in the market could be capable of organizing and managing delivery at home. Obviously, the first one you can figure out by looking at your data. The second one's more of a subjective call. And I definitely think that organizations that meet both criteria are most likely entrants should Medicare stand this up outside of the MA plans. But it's, to me, ultimately going to be a little uncertain as to which entities could check both boxes. So I think you really do have to pay attention to any entity that checks that first box and controls the referral stream, because certainly they could be a potential partner for one of the national companies to come in and provide the infrastructure to manage that risk. It's not hard for me to believe that a national convener like Remedy wouldn't get into this space if CMS rolled out a similar model, given their experience and success at managing bundles in BPCI and now moving into BPCI Advanced. Then finally, I think it's going to be important to understand your capabilities. And so among other questions, acute organizations that execute a hospital at home model are going to need to answer the following types of questions. And these sort of range from a raw ability to provide care, but also the ability to manage subcontractors who are doing things like delivering DME or providing care in the home, because certainly very few entities will be able to do this soup to nuts for all of the patients that may ultimately be attributed to them. And I think the first question is how are you going to determine the suitability of the patient and the patient's home for the model? Certainly there are algorithms for the patient, but then you need to figure out how you're going to get somebody within a fairly quick period of time out to the patient's home to meet someone to get into the home and evaluate. And certainly in terms of the evaluating the patient, obviously a lot of this can be done at the ED. It probably would make sense to have a person there if you're truly trying to scale this up. But for inbound admissions from physicians' offices or urgent care centers, it may imply a need to have a centralized call center solution or a line that goes into the person who's doing this in the ED for potential patient assessment. Second, once you've got a patient's home that's been deemed suitable for the model, how will you get the necessary medical equipment delivered in a timely manner to the home? And beyond considering the geographic boundaries, certainly a hospital may need to develop deeper relationships with DME companies where they're going to offer that model, and making sure that you've got good sort of time requirements or sort of service delivery requirements in your contracts with the DME company that you partner with. Third, once you get the patient admitted to the hospital at home model in his or her home, how's care going to be admitted or administered? The mix of services delivered will depend on the condition-specific care protocol and the severity of the patient's condition. And to address this consideration, hospitals may need to develop hospital at home programs, depending on the volume, and deepen existing relationships with home health agencies, whether they're doing it with their owned agency or somebody that they've partnered with, and then also beef up their abilities to provide telehealth and remote monitoring. Finally, once the patient is discharged from the model, or at least from the home portion of the stay, how's the provider going to monitor, track, and support the patient during the post-discharge window? And certainly providers will need to develop mechanisms to track the patient, repatriate the patient back to their primary care provider, and also make sure that patients are adhering to their care plans. Further, as I mentioned a couple different times in the session, given the role of social determinants of health and readmissions, hospitals are going to need to develop deeper relationships with social service providers to address non-medical needs and certainly reduce readmissions. So with that, and I apologize for being a minute over, but just want to stop here and see if anybody has questions.
Okay, thank you, Chad, so much for that great presentation. So at this moment, we will be opening the panel for questions. Remember that the panel's questions are located to the right of your screen, and we will take as many as the time will allow. The first question I have here, Chad, is are there any cost studies on what the PTAC approval process involves for a provider?
You know, I haven't seen any estimates on what it costs to take something from start to finish with the PTAC. My guess is that, well, actually, it's going to depend on how heavily you lean on consultants to do it. If you're doing it mostly with your own internal staff, it will reduce the actual outlay, but then obviously there's the lost opportunity cost from that person's time. However, I think most places are doing it with some consulting help, which then raises the price. I know that with what Marshfield did, their partner is the company that is is one of the companies that's building a hospital at home care delivery model and platform. So they're trying to build a business out of this. They managed most of the process and paid for the consultants. So it sort of offset the cost for Marshfield to get this sort of taken through. So it's mostly staffing and time.
Got it. Okay, thank you so much for answering that. The next question is, why hasn't CMMI done anything with the recommendations on models recommended to them by the PTAC, like the hospital at home model?
You know, it's frustrating because certainly you've got the industry saying, hey, here's not only where we think there are opportunities, but here are good ideas to address these opportunities. But unfortunately, what's been provided to CMMI and CMS thus far has not sort of aligned 100% with what their agenda is. And, you know, CMMI unfortunately has a limited basket of resources, and they're having to sort of address the models that are in their portfolio first. And it's you know, so thus far they haven't moved. I tend to believe that the models that have been recommended to the PTAC or recommended by the PTAC to CMS will eventually, or many of them will see the light of day. The analogy that I would use is the Medicare Payment Advisory Commission, which provides guidance to Congress. You know, typically when these models, or when the Medicare Payment Advisory Commission makes a recommendation to Congress, Congress, for whatever reason, tends to ignore it for a couple of years until they need a good idea from somewhere to reduce costs. I suspect that we'll see a very similar thing from the Innovation Center that, you know, once they've sort of burned through the stuff that's currently on their agenda and they're working on, they may start to switch to these types of things that were recommended by the PTAC.
Okay. And then the last question here is, how much of the difference is quality metrics between the hospital at home model and patients with similar conditions receiving care in the traditional acute setting is due to differences in acuity?
It's a good question. And my guess is that there is some difference in acuity that isn't picked up in the DRG weight, in the sense that you know, you're kind of self-selecting into the model, number one. Number two, there's a clinical judgment as to whether you're a good candidate for the model. That is sort of would screen out anyone that would be sicker. And then also when they look at the home, there's sort of a social determinants of health overlay on it. So my guess is some of the benefit of the model is as a result of the fact that the patients are somewhat healthier. But the way I tend to look at it is because it is a lower cost model for delivering care, that you're actually not gaming the system in that sense.
Okay. Well, as we approach the top of the hour, I would like to take this time to thank our members and healthcare community for joining this call. As you exit, you will be prompted with a survey. We would appreciate you sharing your feedback about today's event, as well as what kind of topics you are looking for in the future webinars. Thank you again for our guest presenter, Chad Mulvaney of Healthcare Financial Management Association. And on behalf of the First Illinois HFMA, thank you again for joining. Have a great afternoon, everyone.